Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome Patrick Dougherty. Welcome to the program.
Thanks.
So glad you could come in. You are a clinical pharmacist with a specific practice area in the Emergency Medicine Department at Peninsula Regional Medical Center. And you're here to talk about prevention and treatment of stroke.
Yep.
So let's talk about exactly what a stroke is. We know how prevalent they are. They're very common, unfortunately, but we'll talk about the different types of strokes, and then, of course, we'll venture forward into ways that they're treated locally here at Peninsula Regional, and prevention, of course. We'll wrap up with that.
Sure.
So tell us about what a stroke is and the different types.
So a stroke occurs when there's insufficient blood supply and oxygen to the brain. And that can occur via two methods, either a clot or an obstruction impacting blood flow to the brain, or a blood vessel bursting within the brain. So we have an ischemic stroke, which is where a clot or obstruction occurs, and a hemorrhagic stroke, which is where a blood vessel bursts, causing bleeding.
And of course, the risk factors are fairly similar for them. So let's talk about the risk factors as one way of preventing stroke.
One of the biggest risk factors is high blood pressure, but patients with sedentary lifestyles and being overweight or obese can certainly be risk factors as well. Diabetes, patients who are poorly controlled diabetes may be at risk of developing stroke. You have patients with aneurysms within the brain that could be a risk factor for a hemorrhagic stroke. Perhaps patients with smoking use and tobacco use is another big one that puts patients at risk of developing stroke. Tobacco use is very notable for impacting the inner layer of your blood vessels, which is very important to keep intact. And smoking and tobacco use can degrade that inner layer and make the blood vessels more at risk of developing a clot or bursting open.
Yeah, thickening up as well.
Yeah, yep.
And of course, they tend to age as a risk factor the older you get.
Certainly, yeah. As people age, their blood vessels, the integrity of the blood vessels may not be as well maintained as it was as earlier years.
And of course, when you mention being overweight, we have to mention diet, exercise.
Yep, eating unhealthy. There's other disease states like peripheral vascular disease that can impact that. Sickle cell disease, patients who have sickle cell may be a higher risk of stroke. And then patients with atrial fibrillation, which is a disease of the heart where the top part of the heart doesn't pump as correctly as it's supposed to, or fire the way it's supposed to, and that can cause clot formation within the heart, which then can be pumped out of the heart up to the brain, which would be an ischemic stroke. So patients can be at risk for that with atrial fibrillation. And
that's more from what we call an embolism or emboli, a little moving clot.
Yep.
And I know we'll focus more on the thrombotic type, where there's just a slow buildup of plaque in the vessels, and some of that has to do with cholesterol profile. Now you're saying, is genetics a factor?
Certainly. So it's always important to know family's history of cardiovascular disease and stroke, and there could be a family linkage to that, but also genetics plays an important role in the amount of cholesterol that people's bodies produce. Their blood pressure, genes play a role into that as well, and overall body habitus, the risk factors for obesity and diabetes. There's certainly genes that come into play with that, which your genes are your genes. You can't really do much with that.
No.
But the modifiable risk factors are certainly important to be aware of, and to hopefully decrease the risk of stroke by changing those risk factors appropriately.
And I know we'll emphasize this at the end, but getting your blood pressure monitored, checked, and if you do need medicine, taking it as prescribed.
Absolutely, yeah.
Can certainly play a big role.
Keeping that blood pressure under control and monitoring it frequently, daily, would be an ideal situation, but certainly frequently enough that you know where your blood pressure lays, and taking medication is appropriate. Yep.
And just briefly, before we get into the deficits, the thrombotic stroke, which is the buildup of plaque in the vessel that eventually seals off. The good, hate to say good thing about it, there's no good stroke, but as it thickens, sometimes people get a warning sign,
Yep.
correct? So
So
tell us about that.
It's called a transient ischemic attack, or TIA, and a lot of people refer to that as a mini stroke, where the signs and symptoms of the TIA can mimic a full-blown stroke, but they subside more quickly, and the patient doesn't experience long-lasting deficits from a TIA. But the concern is that a patient can certainly look like they're having a stroke from having a TIA, and therefore we want to know of that and take action on that appropriately to hopefully prevent that patient from progressing into having a stroke.
Now, before we get into the treatment, we're going to focus on the treatment and prevention later on. Tell us about why it's so, we know it's important to get to the hospital quickly, but why? What are some of the deficits people can have? And some of them can be significant.
Certainly. So it's very important to get somebody you believe is having a stroke to the hospital as quickly as possible and calling 911. I use the term time is tissue that I probably learned in my education, that the longer somebody goes with a stroke, the more likely they're going to have more severe deficits, or those deficits that they're experiencing are going to be more permanent. So if we can get somebody into the hospital quickly to receive adequate treatment for their stroke, we can hopefully prevent those severe deficits from occurring. And patients with strokes can have deficits of vision, vision difficulties, seeing double vision. They may have functional deficits within the motor functions of their fingertips, their hands, their arms, their legs. Depending on which side of the brain the stroke is occurring in, the physical manifestations are seen on the opposite side. So if there's a clot that's impacting blood flow on the left side of a person's brain, you'll see the physical manifestations on the right side of the brain. So perhaps a facial droop, difficulty speaking, difficulty swallowing, weakness on that side of the body. And those can be very debilitating and potentially permanent ramifications of having a stroke.
Yeah, it can be like a complete paralysis on the
Certainly.
opposite side. I mean, oftentimes we just see weakness and we can do aggressive rehabilitation,
Yep.
but there can be many other deficits associated with stroke. And a lot of times we hear a lot about what we call aphasia or speech
Yep, difficulty
deficits.
speaking, yep. And there's an impact. A good number of patients who have a stroke also have impact on their mood and their emotions, their affect. It can make them feel depressed because they're not living in the same type of quality or experiencing the same quality of life that they were beforehand. So there's a psychiatric component that happens long term with patients with stroke as well.
And I know that piece can be very disturbing to the family as well, because they'll say they're just not there, they're not like they were,
Right.
you know, from a personality and mood standpoint. But many other physical issues, but time is tissue. I
Time is
like that
tissue.
one. I know we always say time lost is brain lost.
Sure.
And the same applies to heart attack too,
Yep.
getting to the hospital quickly. I know they've kind of changed the vernacular somewhat, and they say, well, it's like a brain attack,
Yep.
because it's similar to a heart attack. And I think most of the general public knows you get to the hospital quickly
Right.
for both conditions or symptoms.
Certainly.
So let's talk about what exactly happens if a patient is having symptoms and calls 911 and they come into the ER, because the ER is where most of this really takes place as
Certainly.
far as aggressive treatment.
Yeah, so when a patient presents to the emergency department, either by themselves or by EMS, we activate a protocol to get them treated promptly so that we can provide them with appropriate management. And the first thing that's typically done is the patient is taken to a CT scanner. And the purpose of them receiving a CT scan is to examine the head and the brain to see if there is a bleed. And that helps to determine if we are dealing with a hemorrhagic stroke or if we're dealing with most likely an ischemic stroke. And more patients have ischemic strokes than hemorrhagic stroke, but the way that we treat an ischemic stroke is very important because we can't give that treatment to somebody having a hemorrhagic stroke. So the purpose of the CT scanner is to rule out, essentially to make sure that the patient isn't having an active bleed within the brain. Once that CT is done and it's read by a radiologist and the emergency medicine physician, we're drawing blood to send down to the lab for that to be analyzed. We're doing vital sign monitoring of patients, and then the emergency department staff will also be doing stroke assessment scales. They'll be physically manipulating the patient to see what deficits they have, and they'll score the deficits in a way, and the higher the score, the more severe the stroke is that the patient is experiencing. And from there, once we get the labs back and the CT read, we can make a decision whether or not the patient is a candidate for thrombolytic therapy, which in this case, the medication we use is called Alteplase. And it's a medication that we give to patients that helps their body's blood dissolving system break up that clot. So if the clot is in the brain, we can hopefully help the body break down that clot to help oxygen and blood flow back to that part of the brain, so that we can see a decrease in their stroke severity and decrease in their deficits.
I know we also call these medicines clot busters, because
Yes.
that's what they do. They actually dissolve the
They help
clot.
to dissolve the
pretty
clot.
amazing. How long have they been around?
Oh, gosh, quite a few years now.
Yeah.
There are some older clot busters out there that we don't use anymore, just because they did have higher rates of systemic bleeding with them. So the newer agents that we use are more targeted to an active clot. So the bleeding risk is still there, but it's much less now, which is definitely better, because if patients were to have a severe bleed within the brain, despite us using that, it would be unfortunately
And that's why that CAT
That's
scan is so important, because you would
Absolutely.
never want to give a patient with a bleeding type of stroke a clot buster.
thrombolytic. No, you could worsen the bleed.
Right, but they're very essential in the treatment of the
For an
ischemic
ischemic
type stroke.
Sure.
And this is all done in the ER. Now, there is a window of opportunity to give this drug, and that's why we want to emphasize this, because it's
Certainly.
important to get people to the hospital quickly.
Yep. So the drug is approved for a 3-hour window from the onset of stroke-like symptoms to 3 hours after that is where the drug is approved. But the guidelines, which we base our treatment decisions off of, will expand the window up to 4.5 hours for certain patients. So there's kind of two different windows there, ideally within three hours, but certain people up to 4.5 hours. There's evidence and clinical studies to support doing that as well.
But I know PRMC is a certified stroke center, and they have a goal of trying to give the medicine within 45 to 60 minutes?
Yep, the Joint Commission for Accreditation of Hospitals certifies PRMC as a primary stroke center, and our goal is to administer Alteplase to patients having an ischemic stroke within ideally 45 minutes of their arrivals. 45 to 60 minutes is kind of the current window that we're aiming for. And that's why things happen very quickly within the emergency department when we call a code stroke. We get that patient to the CT scanner, we get the labs drawn, we get their vitals analyzed, we do the NIH, National Institute of Health stroke scale on them to assess the severity, and we get the ball running as quickly as we can. The medication takes a few minutes to mix up and to make sure that you've dosed it accordingly, and double check everything, and then off you go with it if the consent is given to give the medication.
So if a person can get to the hospital quickly, the system is set up at Peninsula Regional ER, emergency department with the triage and such. You have symptoms of a stroke, right back.
Yep.
So that all this can go into motion.
Whether the patient arrives by somebody drops them off or they arrive by an ambulance, we have the protocol in place to get that patient back to be seen promptly so that we can get them treated as quickly as we can if they fall within the window of treatment for us. And we've seen some very good outcomes from patients who are treated promptly with very high stroke scores that come down after treatment in the acute setting, and then we've seen some patients with those scores coming down a few months after the fact, which is where really the benefit of the drug, the thrombolytic that we give, the clinical benefit is seen 3 months after you give it. But we have some patients who, in the acute setting of the emergency department or their hospitalization, see significant improvement. And we've been able to get alteplase to patients within 20 minutes, 30 minutes of arrival in some cases.
And typically, over what time frame would you see the deficits, start diminishing?
You would hope within the next few days of their hospitalization that the deficits start to improve and their stroke score comes down. But stroke is a long-lasting disease state, and it may take months to really see improvement in motor function and mental status, in cognition, in their speech, and that's why there's so many different realms of therapies that have to come into treatment.
Right, that's also supported by the evidence that aggressive therapy, whether it's physical therapy, speech therapy, and so forth, can really help with that. I just want to briefly ask about if someone comes in with the mini-stroke symptoms. I mean, sometimes they can go away in 15, 20 minutes, and that's often the time when family members or so forth say, well, it went away, let's just leave it alone. Shouldn't they still come to the hospital?
They absolutely should. The concern is that if they've had a TIA, they could have another one very soon, or that TIA could progress into a stroke. So patients with a history of TIA, you're not sure if it's another TIA or if it's an actual stroke that they're having, because their signs and symptoms are synonymous. They look just like each other. And so therefore, if patients are having a TIA, it is definitely recommended to still call 911, to still get your family member or your loved one, your friend to the hospital as quickly as possible so that they can be assessed by an emergency medicine physician and likely a neurologist, and they will make a decision whether or not they think this is a TIA or a stroke and decide on appropriate therapy.
Now let's just briefly address treatment of hemorrhagic stroke. I know, let's go beyond the ER. A person's admitted to the stroke unit. PRMC has a dedicated unit for stroke patients. So hemorrhagic stroke, the treatment's a bit different. Obviously, no clot buster there, but and then we'll focus more on the thrombotic, embolic type.
So for a hemorrhagic stroke, it's really about blood pressure control. Most patients who have hemorrhagic stroke have profoundly elevated blood pressures. And so the goal is to decrease their blood pressure to prevent the worsening of the bleed within the brain. The higher the blood pressure, the more blood flow may be occurring within the brain, worsening that head bleed. So we want to keep the pressure under control. We don't want to drop it too low. The patient does require a perfusion of the brain with that blood flow, but the aim of a hemorrhagic stroke is normally to decrease the blood pressure accordingly, and then make sure that there's not an increase in the pressure within the head. So we might need to alleviate that either through other medications or through neurosurgery if it's indicated, depending on where the bleed is and what the neurosurgeon would have to say.
And since we don't have a clot buster that can take care of it, these have a little bit more problematic outcomes, although luckily they're less common. And they can be prevented. I can't tell you how many scenarios I've seen when I took patients to the stroke unit of people that just stopped taking their blood pressure medicine, and then they experience
what's usually described as the worst headache of someone's life, and that's indicative of perhaps a hemorrhagic stroke occurring.
So let's focus more on thrombotic. A person goes to the floor, they've gotten alteplase or not, but there's other medications that we use, actually more for prevention of future strokes, right? Correct?
There are, and there's actually one thing I think is important to discuss as well in the acute treatment setting of a thrombotic stroke or ischemic stroke is mechanical clot retrieval. So that's a newer modality that certain hospitals can utilize, where a catheter is thread up the artery, usually within the leg, up to the brain, and using special imaging techniques, an interventional radiologist will retrieve the clot from the brain, actually pull it out either through a suction or use a little stent and pull the clot out itself. And the results from that have been amazing. And there are patients who go back to at their baseline after having a clot retrieval process done. It is a little bit more cumbersome to do, very tricky in nature. You have to make sure you have the right imaging techniques and the right people, right staff at the hospital to do that. We can do it at PRMC. We do have the capability of doing it there. some bigger hospitals are more notable for doing it, like University of Maryland, Johns Hopkins, other bigger institutions have that capability.
Is there a time frame for that?
Usually within 6 hours
Okay.
is the goal for that. And if a patient has received alteplase for their ischemic stroke, they can still go on and get a clot retrieval if indicated for it. So part of our protocol at PRMC is to assess a patient whether they're a candidate for alteplase if it's an ischemic stroke, but also are they a candidate for clot retrieval depending on the severity of the stroke, and if necessary make the appropriate referrals to another hospital if we are unable to do it at that time.
Okay.
Yep, but you were going down the post-treatment here,
Right,
the long-term
right.
treatment. So
I did have a question though. Years ago we used to use heparin. That's all we had. Is that still used at all, or?
Not quite so much in the acute setting of a stroke. You may have an indication for it in some patients, perhaps if they're not a candidate for alteplase therapy, or they're not a candidate for clot retrieval. The physician may want to start a patient on a heparin, which is a blood thinner, an anticoagulant in that setting. But most of the time, if a patient can't receive alteplase or clot retrieval, we actually give them aspirin. That's the drug that
The
we
wonder
give.
drug, huh?
Yeah, to help. Aspirin stops the platelets from clumping together to thereby hopefully preventing further clot formation.
And most people will be prescribed an aspirin every day. Go home on that. Or...
Right, so and the chronic therapy of somebody who's had a stroke, they're likely going to be placed on aspirin.
And what about the role of statins, the drugs that we use to help with cholesterol?
Yep, so statins will help keep patients' bad cholesterol levels down, hopefully give them a good cholesterol levels as well. So patients who have had a stroke can likely anticipate being placed on a statin to help prevent further plaque formation within the arteries and blood vessels of the brain.
So just briefly, if you wouldn't mind summarizing the treatment plan when someone leaves the emergency department and is admitted to the stroke unit. You know, what is the focus there?
So once they leave the emergency department, they may go up to the ICU or to the stroke floor from there. And they're going to be admitted for a few days for the purpose of monitoring the patient to make sure that the stroke isn't worsened or that they don't have a bleed if they have received alteplase. And they're going to be seen by a lot of people, a lot of different specialists. You'll have, if they have speech deficits, certainly a speech therapist, speech pathologist going in to help them with speech therapy and occupational therapy, physical therapy. Those specialists will need to see the patient for any motor deficits that they may have and to get them back, hopefully, to work within the confines of their normal daily lives. They can anticipate being on some medications from there, as we talked about, aspirin and statins, medications for their blood pressure. If that's been elevated, they'll have to receive antihypertensives, some blood pressure lowering medications for that.
Yeah, the other thing we didn't mention is it can have effect on swallowing.
Sure.
That can be very significant.
Yep.
So oftentimes they're not given anything to eat or drink until they can be evaluated.
Yep.
For that, and that can be significant.
Absolutely, and that
affect
can
nutrition and so forth.
Certainly, so the ability to swallow and feed yourself after having a stroke can be quite impaired, as well as the ability to swallow medications. And so therefore, you have to have that swallowing mechanism in place in order to really receive the best care that you can for stroke with the medications that we will need to give.
And the good news is many of these deficits can improve with aggressive therapy and
Yep.
so forth, or the stroke the blood is reabsorbed and the blood flow is restored and people can return to either normal function or improved with aggressive
Yep.
therapy. I think that's the good news. And stroke, of course, is one of those examples of interdisciplinary collaboration.
Absolutely.
So many different disciplines are involved, including the nurse, of course,
Yeah.
the doctor, and all the various therapies and so
It
forth.
truly is, and it's a disease state that you see in the acute setting, and then you see months on end, years on end, and the ramifications of it that it can have. So it is a chronic disease state. I certainly deal with more in the acute setting, but I see patients who have had strokes, and the complications that can come from having a stroke can be very severe and debilitating for patients. And we do the best job that we can within all of the different disciplines to get that patient on the right track and with the right therapy provided to hopefully prevent those bad complications.
Right, preventing a stroke is the best medicine, really, and let's focus on that now. We know with the hemorrhagic type, that's often from elevated blood pressure, so making sure you check your blood pressure and keep it under control with the medication. So let's focus more on also preventing the thrombotic type. We've already talked about not smoking, diet, exercise, keeping your weight down, managing your diabetes.
Absolutely.
And then let's emphasize that acronym, the importance of time is tissue. It's called FAST.
The FAST, F-A-S-T.
So tell us what that means.
So F would stand for facial droop. If you see somebody with one-sided facial droop, that could be indicative of them having a stroke. And then you would want to test their arm weakness on that side of the body. And if you find that they're weak on one side or paralyzed on one side of the body, that stands for the A, arm weakness.
Ask them to squeeze your hand.
Ask them to squeeze your hand, ask them to talk to you and see if they're having any speech difficulty. So there's your S. If they're having difficulty speaking or they can't speak at all, they're aphasic, they're having slurred speech, that's indicative of a stroke. And then that T means it's time to call 911, get EMS on board to get that patient, to get that person to the hospital.
Yeah, that's the best case scenario versus driving yourself or having a family member take you. Call 911.
And the big benefit that calling 911 does provide is the paramedic or the EMT will call the hospital ahead of time and say that we have a code stroke patient, we're coming in. That way we can get the ED ready. We know that we have a patient with a potential stroke coming to us. We can make sure that the CT scanner is available so that when they come in, we get them quickly registered into our system and rolled right back to the CT for that scan to be done, because that's very important to happen.
Time matters
here. We want to get things going
yeah.
as quickly as possible. Yeah.
Well, thank you so much for all this wonderful information about stroke. We've done several shows on stroke over the years. It's just so important.
It is.
And that people know that they should get to the hospital quickly, and that Peninsula Regional has an excellent system in place for aggressive and prompt treatment. And it's all helped outcomes. We have the research, nationwide to support all these different interventions and that they do work.
Absolutely. It's a big disease state and we need to be on top of it.
So thank you again, and I know you brought some websites that I'll post at the end of the program where people can get more information.
Great. Thank you very much.
And thank you for joining us for this edition of Focus on Health here on PAC 14.
When someone is having a stroke, every minute counts. Just as putting out a fire quickly can stop it from spreading, treating a stroke quickly can reduce damage to the brain. If you learn how to recognize the telltale signs of a stroke, you can act quickly and save a life, maybe even your own. For both men and women, look for these 5 signs of a stroke, all of which come on suddenly. 1. Numbness or weakness in the face, arm, or leg, especially when felt on just one side of the body. 2. Confusion, including trouble speaking or understanding speech. 3. Trouble seeing, from one or both eyes. 4. Trouble walking, or problems with balance or dizziness. 5. Headache, especially a severe one that comes on suddenly. The clock begins ticking as soon as you spot the signs of a stroke, because some treatments can only be used if the patient reaches the hospital in the first 3 hours after symptoms appear. So don't wait. Call 911 right away and get the person to a hospital immediately, even if the symptoms go away. If you think someone is having a stroke, remember the word FAST. F is for face. Ask the person to smile and check whether one side of their face is drooping. A is for arms. Have the person raise both arms and see if one arm drifts downwards. S is for speech. Ask the person to repeat a short phrase and notice if their words sound slurred. And finally, T is for time. If you spot any of these signs, call 911 right away to get the person to a hospital fast. Strokes are medical emergencies. The sooner a patient gets treatment, the better their chance of a good recovery.